This patient has a history of sick sinus syndrome with symptomatic bradycardia, and a pacemaker was implanted. The telemetry electrodes are attached. The white electrode goes on the right shoulder, the black on the left shoulder, the green on the lower right abdomen, and the red on the lower left abdomen. Have the patient lay back and place the wand over the device. The programmer will either automatically boot up or tap the Find Patient button. Once the interrogation is complete, the startup screen will be visible. Note that this screen and device testing will vary slightly by manufacturer. The top line shows the patients presenting rhythm in lead 2 with marker channels showing atrial pace and ventricular sense with some PVCs. Print out a strip showing the presenting rhythm. Here the rhythm shows atrial pacing and ventricular sensing for 4 beats. The 5th beat is a PVC, which the VS demonstrates. The 6th beat is atrial and ventricular pacing, and the AR reflects far-field R-wave sensing on the atrial lead. Evaluate the data on the startup screen. This includes battery voltage, percent of time pacing, and arrhythmic episodes. This information can also be obtained on the printout for percent pacing and for arrhythmic episodes, called clinical status here. Lead impedances, values, and graphed trends are viewed next. The graph should form a relatively straight line. If there was an abrupt increase, this could indicate a lead fracture, and a decrease could indicate an insulation breach. Printouts may be easier to read for the atrial lead and for the ventricular lead. The sensing test is performed next. If there is pacing in either chamber, the rate needs to be decreased to allow the intrinsic rhythm to come through. This device measures both the P and R wave amplitudes at the same time. Use the DDD mode and increase the AV delay to prevent ventricular pacing. Decrease the lower rate to allow the intrinsic rhythm to come through, to a minimum of 30 beats per minute. Here the test mode is DDD, AV delay is 350 milliseconds, and lower rate is 40 beats per minute. The second beat is the native conduction, seen by the AS and VS markers. When the test is complete, print the results of the P wave and R wave amplitudes. Lead threshold test is performed. First, the atrial lead is tested in the DDD mode with the rate about 5 to 10 beats faster than the intrinsic rhythm. For this patient, the amplitude was automatically decremented, starting at 2 volts. On this programmer, the test button must be held for the duration of the test or until capture is lost. Review the test rhythm strip. In this case, there was good capture at 0.5 volts, as evidenced by the presence of P waves after the AP marker on ECG lead 2 and the absence of any atrial sensed events. Since 0.5 volts is the minimum test value and capture was still evident, the threshold is 0.5 volts at 0.4 milliseconds. Next, the right ventricular threshold is tested. VVI mode is used at a rate about 20 beats faster than the patient's intrinsic heart rate, or 90 beats per minute here. DDD with a short AV delay may also be used. The ventricular electrogram should be visible on the screen to easily see loss of capture. Similar to the atrial lead, the output is automatically decremented starting at 2 volts. The test button is held for the duration of the test or until capture is lost. The test strip is reviewed. This shows ventricular pacing even at 0.5 volts. If there were loss of capture, there would be a ventricular pacing stimulus but no QRS. Since 0.5 volts is the minimum test value and capture was still evident, the threshold is 0.5 volts at 0.4 milliseconds. At the end of the testing, parameters for both sensitivity and threshold are examined to ensure good safety margins. The sensitivity should be programmed to at least half of the size of the intrinsic P and R waves, though it's frequently programmed to about 0.3 millivolts for P waves and 0.3 to 2.5 millivolts for R waves. The pacing output should be at least 2 times the threshold voltage or 3 times the pulse width. The amplitude outputs in this case were both programmed to 1.5 volt. In this patient, because of far-field R-wave oversensing, the postventricular atrial blanking period was extended slightly to 170 milliseconds. At the end of the interrogation, print out the final report. This shows a summary of the battery voltage, lead parameters, and device settings. After the final report is printed, print out the report for changes made during the session. This allows for review of parameters that were changed to ensure they were completed correctly. The wand and telemetry electrodes are removed. The session is ended and the pacemaker interrogation is finished.